Thanks, Senator. I can bring it close to your, there you go. Thank you.
Thank you. Will you join together, bow our heads in prayer? Father, we ask thy blessing on this gathering. We are here humbly seeking the wisdom and the courage to do what's right for the people of this state. We welcome all in the sound of our voice to come together for solutions, addressing the needs of our state, and upholding the motto of Georgia, demonstrating wisdom, justice, and moderation. Bless these proceedings, we ask in thy name. Amen.
Thanks, Senator Rock. And thank everybody for being here. We've had where the representatives, Todd Jones, Mayor Margaret Oliver, presented House Bill 1013 to us. It's been 2 weeks ago, as a matter of fact, 2 weeks ago, and we've had subcommittee meetings, two more that week, two last week, and here we are in the full committee again. The first order of business actually is to dissolve the subcommittee, of which Chairman Burke had done. So we're going to dissolve that. But I would like for him, if he has any comments, to comment relating to the subcommittee, and then we'll get on with our business.
Thank you, Mr. Chairman. Appreciate the opportunity to serve this committee and working on House Bill 1013 in subcommittee. I want to thank the subcommittee members, and unique, I think, to this Senate side, we had the chairman of the Insurance Committee, the chairman of the Judiciary Committee, and the chairman of the Health Committee, all on that subcommittee. And if I'm not mistaken, that's at least 30 plus years of legislative experience serving this committee. And we had several other august members of our subcommittee, Senator Kirkpatrick, who has done significant legislation in this space, and Senator Al, who's learning fast in her role on this committee, and I want to thank them for their work. We had at least 4 subcommittee hearings, heard probably 6 hours of testimony added together, and obviously there's plenty of input from both the public and advocates on the issue. So I want to thank everyone involved, and I think we will be significantly moving the ball forward in this mental health arena, and I think the work of the House and the Senate will be work that we'll be proud of in the future. So I wanted to thank everybody involved, Mr. Chairman.
Thank you, Senator Burke. Appreciate that. Appreciate you chairing up that subcommittee. I want to do a little bit of housekeeping. Listen, I appreciate everybody's input on this, and it's been a journey. This is where we are. Just on the details of that, signs don't bother me at all, but if they are bothering someone, they don't bother me. I welcome them. But if the signs are bothering your neighbor or somebody from behind, we want to be respectful today, and let's continue to be that way. I appreciate everybody being that way. We are live streaming in the back, so that red light is live streaming, so we don't want, especially here, holding up signs at the very back row. If you want to hold up sign, perfectly fine by me. Jeff Breedlove had pointed out earlier when he testified with the public testimony that the outburst of cheers and jeers, I will tell you that is disturbing to me and is disrespectful to the speakers, and so I would ask you to keep that down. I do not want to have to ask our Capitol Police and State Patrol to escort you out. If you got to do the outburst of cheers and jeers, just feel free to step outside, and I think they'll let you do that, unlimited by all means. But we want to do the people's business here and try to get take some action today. So thank you very much for that. So having said that, we are at the dissolution of the subcommittee. So now we're in the full committee on the Senate Health and Human Services. Our order of business, the way we're going to do this is that with Chairman Burke's help, we do have the substitute, which is in everybody's folder, and I've hand-delivered it to almost everybody, and our intern has helped out with that too. We're on LC 33915-2S. That is the final substitute that we've had. We've had several drafts along the way. Also in your folder is the original from the House, also there, and we have the fiscal note from the Department of Audits and Accounts. So that is in your folder. We do have a potential small amendment there of tweaking a little bit of language, and that will come up later, but that's sort of where we are. What we're going to do is Chairman Burke is going to do sections 1 and sections 2. He's going to take us through the changes from the House version, and then I'm going to do sections 3 through 6, and we're going to take you through the House versions, the House changes at that time. And then what we're going to do is we're going to have questions from the committee. Hopefully we'll exhaust those questions, and then we're going to vote. And so that's going to be our order of business. Chairman Burke, anybody has any questions about the way we're going to proceed? Okay. Thank you, Chairman Burke. The floor is yours.
Thank you, Mr. Chairman. First off, I want to just kind of speak to the direction that the Senate took in this legislation, and I do want to say, because of the length of the bill, I'm going to be giving an overview of the changes and the substance of the changes, and if we tried to go through every single change in the bill, we would not be finished before midnight probably. So, but then be glad to stand for questions if people need a little more in-depth information. Of course, this is what we call the parity section of the bill, and our plan was to try to get at what the federal law contemplates, which is that mental health conditions will be treated in parity with acute care, or what some people call medical surgical care. So that was the goal of the changes in the subcommittee. Starting on line 53, and this will be consistent throughout Part 1, we've defined addictive disease as it's defined currently in code in 37.1. We changed some of the wording in lines 54 to 64 to make sure that we were using evidence-based standards, peer-reviewed documentation, and consensus guidelines. We defined healthcare plan in line 65, health insurer in 68, and medically necessary line 75. On line 86, just as we did defining addictive disease, we defined it mental health or mental illness as the same as in Code Section 37.1.1. NQTL definitions were there as well. Now, what I call the mandate for parity begins on line 107. And that basically says that if a health insurer provides coverage for mental health or substance use disorder as part of a health care plan, then that coverage must meet, and the rest of the lines basically are quoting the federal parity standards. The next section of the bill contemplates what the Commissioner of the Insurance will do in regards to reporting, and the main changes that we did in this Senate version was to cut down on the number of items that have to be reported, mainly so that we could get what we would consider a workable document. You know, when you're reporting 50 things, it's hard to understand what's important, and so this gives direction for what we felt like were the most important things to be reported, but then also give the commissioner the flexibility to add anything that he or she feels is necessary. And then on lines 173 to 185, there's some fines for a violation if an insurer does not report information. There is gives the commissioner the ability to give a monetary penalty and other restrictions that are outlined between 181 and 185. Now, the following sections of the bill are basically somewhat repetitive because there are a lot of different areas of code that affect different types of coverage and policies. So, you know, big groups, small group, and so forth. So those are outlined in those following sections, sections 1-5, 1-6, 1-7, and I don't think it would benefit the committee to go through every one of those because they're very repetitive. One thing I do want to bring out, there was a lot of concern about DSM and WHO standards in that early part of the bill. Those were completely removed from every definition. Section 1-8 outlines the appeals process, and
What line are we on?
we're page 24, 613, and this basically just reviews the Medicaid appeals process if someone feels like they're contesting a decision. And we removed some of the House language basically because we were assured by the department that their process includes all those things that were in that bill, and it would be duplicative to add them again. So that's a general overview of the parity section. What our goal was trying to accomplish, as I mentioned, was to make sure anyone that's covering mental health in Georgia does abide by the federal parity law, but we weren't requiring or mandating that in any plans that don't have mental health coverage that they had to, and that's something that was we were hearing over and over during our evaluation of the House bill. Section 2, we didn't make many changes. That's this workforce section of the bill. We did broaden on line 665 to primary care medicine. Dr. Watson and myself both consider ourselves primary care medical professionals, and we both have long experience treating mental illnesses in our practices and the use of specialization for referrals. So we do contemplate, though, which I think is, in my mind, one of the most important pieces of this bill, that we can provide service cancelable educational loans to those people that are going into the different areas of mental health and substance use professionals to make it easier for them to get their degrees, and also to make those positions that we have in Georgia more enticing to someone who maybe is coming from out of state and would look forward to working in our great state. Section 2, which is starts on line 80 of Section 2.2, basically gives the Board of Healthcare Workforce
780.
780, yeah. The Board of Healthcare Workforce that already does workforce data mining for the physician world gives them the ability to add workforce data gathering for all of the licensed mental health professionals, behavioral health professionals, and addictive disease professionals. Because right now we don't really know what we don't know when it comes to access to care, and the demographic information and the type of practices and the type of insurance that they take, all those are important data points that will be determined on surveys that are done at the time of licensing. And that information, I think, again, will be extremely important in the work we're doing to try to enlarge our mental health workforce. That's a 100,000-foot level overview of sections 1 and 2, Mr. Chairman.
Thank you, Chairman Burke. We appreciate that. So sections 1, parity, sections 2, workforce, and then section 3, part 3 is the involuntary commitment. And we're on page 33, then page 34. As Chairman Burke mentioned, the DSM and World Health Organization is out the definitions, and we defined addictive disease. We did leave out the first section of that because that was statements or verbiage to be not put in code, but was just more of a statement, and that's why we had left that out. And that's just sort of the Senate position. That's what we've always done. So the bill, as you may note, is gone from about 77 pages to about 69 pages, partly because of that and partly because of reorganization of the bill a little bit relating to councils and task force, which we put back to the commission, and that's actually in the last section that I'll mention. So back to page 34. So changing the definition or adding the definitions in there, and then the lines 869, 870. So the all available resources in motivating the patient to engage with treatment rather than specifically asking the court, whether it's accountability court relating to sentencing. That was our verbiage there from that perspective. On the next page, we did change a few words there, 879 at the end of the treatment program rather than at the end of the commitment program, because when you do a Form 1013, that's an evaluation and not necessarily a commitment. It is not a commitment until 3 days and it's done by a probate court judge. So that's there. And as Chairman Burke had pointed out, the same with the mental illness in the code section 37-1-1. That's the reference there, mental health, mental illness, and then the same with the addiction. Page 36, there were no changes. That's the funding opportunity, DBHDD, and no changes for the next couple of pages. And then the assisted outpatient treatment, line 952, that's where that begins. That from that perspective, how that was addressed was with on page 41. So we changed the policy relating to inpatient and imminent harm to self and others. We left that in code and did not address that, but did address outpatient, meaning a person who's mentally ill, and that's section 3.2, and then the section 3.4 has to do with addiction or substance abuse. So that was, you'll see lines 1038 down to 1046 has to do with outpatient treatment rather than inpatient. Section 3.3, which is in between those two, was a portion that, since it was not defined, the mobile crisis team, we removed that and left in the old language, but starting at line 1067 through line 1078. That was the area there that the police officer, in conjunction with consultation with a physician, either in person, via telephone, or telehealth with a physician, could take the person to an emergency receiving facility for a 1013 form from that standpoint. Okay. So the same adage on page 44, the same is there relating to consultation with a peace officer, in consultation either in person or via telephone or telehealth with a physician. Same language there also. In part 4, mental health courts and corrections, we did add on line 1137, subject to appropriations, which was new, and on line 1139 we removed the gender-specific portion of that relating to implementation of trauma-informed treatment. The word change on line 1141, rather than a designated person, we use the word designated person rather than dedicated, implying that a person who is designated could be in their full-time or part-time position, and not necessarily a dedicated employee, but certainly that is to their discretion. But it doesn't have to be, could be a person who has a dual role. The next page, page 46, with no changes, and then section 4.3 has to do with the Governor's Office of Health Strategy and Coordination. Line 1174, we did add, including overseeing coordination of mental health policy and behavioral health across services across state agencies. And then lines 1199, rather than having two formularies, one relating to Medicaid and the other relating to state health benefit plans, we had one unified formulary for both Medicaid, Peach Care for Kids, and the state health benefit plans. So it would be one formulary and not two. The lines 1223, this is still in the office, Governor's Office of Health Strategy and Coordination. We strengthened that language in 1223 through 1227, actually down through 1234. The 1236 was not new, except for we did correct the language relating to certified peer specialist in line 1252. We used the federal words there, and the rest of that was unchanged. We do have a new section that we did add, section 4 through 4, which was actually recommended through coordination with House Bill 570, Yasmin Neal, who is a House Democrat, who actually I served with when I was in the House. But she had a really good suggestion from our standpoint relating to GPSTC, or Georgia Public Safety Training Center, adding in relating to training relating to peace officers. So 1277 was behavioral health co-responders. We added in that language. And that has to do with education, as most of you know. That's how law enforcement are post-certified from that perspective. Peace officer safety training, going through Georgia Public Safety Training Center. So section 4 through 5, no changes, but we did remove the portion relating to testimony that we received was here that Department of Behavioral Health, Developmental Disabilities, that we use DBHDD language there, that they were not doing co-responders and had not helped in any way. So we did remove Section 3718 out of the House version, but we still have Senate Bill 403, which is in House rules right now, which we've already done here in the Senate. Section 4.6, no changes. That's the grant program relating to Criminal Justice Coordinating Council. 4.7 was also left in with encouraging or shall provide funding 5 new co-responder programs. Right now, if I remember my numbers correctly, there are 23 community service boards. I think there are 6 that are involved. There are 15 different jurisdictions that have co-responder units, and there are 2 that have done it with law enforcement only, though the one in North Atlanta area is actually working with Community Service Board to engender them also in Brookhaven. So the Section 4 through 8, no changes again, except we did leave out the verbiage or the statements with that. No change in Section 4.9, Behavioral Health Coordinating Council, and no changes for the next couple of pages, except instead of including infants, children, adolescents, and adults, we took out infants and left in children, adolescents, and adults from that perspective. And that was a consistent theme throughout the bill, that we did take out infants from that perspective. Part 5, child and adolescent behavior health. That is from that standpoint, the no changes, including keeping in the multi-agency treatment of children, which is really where departments communicate with each other, trying to troubleshoot and work through problems relating to that particular, to mental health and substance abuse disorder. Section 6.1, no changes there either. And then Section 6.2, we tried to take out as many councils and task force as possible, and in charge the Behavioral Health Reform and Innovation Commission to authorize them to continue to collaborate, coordinate, convene, and do subcommittees as much as possible. And the date relating to, dissolution. I don't see that right in front of me, but we did, because of putting in the councils and 1721. Okay, thank you. I knew it was there somewhere. There it is. It's only one simple line that struck. So the commission will be abolished instead of June 30th, 2023. We changed that to 2025, since we encouraged the commission to do all the what was asked to be done by task force and councils and things like that. So just continue with that business. No changes in 6 through 6.4, and we did make a minor change online relating to 1741 and 1742 relating to prescription drug coverage for mood disorders, psychotic symptoms, bipolar disorder, schizophrenia, delusional disorders. So we added mood disorders and bipolar disorder relating to that aspect of that, having to do with prior approval and prescription drug usage. Okay. Chairman Burke didn't see anything I left out, and I didn't see anything he left out, but this bill has gone from, as I said, 77 pages, 69 pages. It is a lot to digest. I got to applaud the House for their diligent work, for what they have done, and it has gotten this ball rolling. We have been working with the House, and we will continue to work with the House relating to this. I'd like to open it up for questions from the committee. And Senator Jackson looks like he has his hand up first. Witness 3, I think that is. Floor is yours.
Yes, thank you, Mr. Chairman. I'd like to refer back to page 43, section 3-3, beginning with line 1066. When it comes to a peace officer may take any person to the emergency facility, Mr. Chairman, does that peace officer has any training? And I know it goes on further to say after consulting with either in person or via phone or via telehealth with a physician. I'm just saying when that police officer consults by phone with a physician, does that police officer have any training to diagnose, to tell the physician on telephone what's actually going on? Or is that required?
Well, I mean, it should be with telehealth, with whether you FaceTime or whether you're doing telehealth via your virtual visit, that many times what we generally do when we have that is that we have maybe a spouse or a child with that particular patient. So the physician should be able to ascertain that information on his own right there on the spot. Having said that, peace officers through post-certified, there is some behavioral health training there, but not as much as we're going to engender. Remember, we added that through Yasmin Neal through at Georgia Public Safety Training Center.
Okay. Follow-up question, Mr. Chairman?
Yes.
So you're saying the peace officer will have some mental health training?
That section was added. Yes.
Okay. Thank you.
Chairman Dolezal, 3.
Yes, Mr. Chairman, thank you. A couple quick questions, if I can. I want to make sure I heard you correctly. I believe you stated that all of the references to DSM-5 and WHO have been removed from the current bill and we're using existing Georgia definitions around mental health.
Yes.
Is that correct? And to follow up with what Senator Jackson asked relative to the peace officers in that piece, the involuntary inpatient provisions of this have been completely removed. So what some folks were concerned were perhaps a red flag, a gateway to a red flag law. That piece has been removed where you can no longer be involuntarily confined. I should say we're not changing the definition of how you can be involuntarily confined. We're reverting back to existing law in this version of the bill. Is that correct?
What you said is accurate. Yes, the imminent harm to self or others is not changed. And so that you remember to quote-unquote lose your gun, you have to be involuntarily committed. And it's not just that. Remember, the first 3 days is an evaluation. The first 72 hours is an evaluation. It's not until you go in front of a probate judge would that happen. And we did not touch that at all.
Okay. You mentioned the mandate. If I could paraphrase the mandate, and you could tell me if I have this correct. This mandate protects direct primary care and existing insurance plans from having to add mental health coverage that they do not currently have. However, if a plan currently offers mental health coverage, they are required to follow the 2008 federal order as it relates to parity.
That's accurate, and I'll let Chairman Burke.
I think that's an accurate summation of our intent.
You mentioned, I think, Chairman Watson, that nothing really changed in section 6, but in my reading of this, which was quick, so please tell me if I'm wrong, the new commissioner and kind of the new department and then everything has been removed from this bill. You're moving the things that were envisioned to be under the new commissioner in the previous bill. You've moved that under the existing mental health commission that's been in place for 2 years. Is
That's accurate? Yes, I may have misspoken there.
Okay.
Sure.
The bill, our version does designate the Office of Health Strategy and Coordination, which is in current code that already has oversight and coordinating in the healthcare world in general, but it gives that office additional statutory oversight of mental health treatment in Georgia. And again, the whole purpose of that is to have somebody that's trying to observe effectiveness and avoid silos and fragmentation, where one agency, Human Services, is dealing with their charges to take care of the foster kids and defects type cases. Frequently those have mental health conditions, and so the whole idea of the Office of Health Strategy and Coordination, as far as its reason for being, is to help oversee the different state agencies that all have their little finger in the pie, to be sure they're working together and that they were having an efficient utilization of resources and effectiveness. And so we did give them that designation, and the work of the commission will continue to go forward, and they've already have subcommittees working on specific issues, and they can continue to bring forward their ideas for us to consider strengthening some of these areas if what our first attempt doesn't. But we tried to not expand government in a way that we can get the same information without developing a new council, so to speak.
All right, and specifically was the line 1174, page 46, and Chairman Burke actually used the word that we changed and what I've termed as improved for the Office of Health Strategy and Coordination, and that's line 74, including overseeing coordination. So that was it. And then, yes, back to the commission, correct.
Do you have time for two more questions? I believe you mentioned one thing that I think a lot of us had questions about in the previous bill was the mobile crisis teams. This bill no longer contemplates assistance.
It just so that was taken out of the bill. It was not defined. We removed that, but we're pushing, relating to the co-responders, which, again, are present, have sprung up without the state's help, so to speak, and has not cost the state any money, because most of those have been through federal grants and or locally, like Chief Flynn or Sheriff Flynn, I should say, up in Forsyth County, actually in your county.
Sheriff Freeman, yes, correct.
Yeah, Sheriff Freeman. I'm sorry, Freeman, and then down in where I live in Chatham County, the commission actually is supplementing that, because listen, they're paying for jail space for people who have mental illness or substance abuse disorder rather than getting treatment. So that's that. I'm sorry.
You can come back to me. I've got more questions.
Okay.
All
All righty. Anybody else have any questions? All right. Dr. Al, number 9. 10. Okay.
Thank you so much. My question has to do with criteria to determine medical necessity as detailed in Section 1. And Dr. Watson and I, we talked a little bit about this, and I talked with Dr. Kirkpatrick about this also. Can you discuss a little bit about how, under the substitute version of the bill, we're going to determine medical necessity? And I realize that depending on the type of insurance that's offered, they may use different criteria. For example, Medicare, we know, uses a national coverage determination, but private insurers can offer non-Medicare plans can often set their own criteria, which may or may not mirror Medicare's standards. And even though they're required to provide coverage in compliance with state and federal benefits, we know that obviously the impetus or the motivation behind this bill is that sometimes insurance companies do not comply with federal standards. So can you talk about how in this substitute bill we're going to set this medical necessity definition outside of clinical or professional society standards?
Right. We did make adjustments there, and we have open conversation with the House. We wanted to make sure that we did use, the valid, as we said in line 58 there, evidence-based, nationally recognized standards of mental health or substance abuse disorder, including peer-reviewed scientific studies, medical literature, consensus guidelines of nonprofits, healthcare provider, professional associations, specialty societies. Listen, I practice medicine, you do too, and There are times that we may witness things that may have been overutilized. I think that is a small percentage, but I don't think that we can discount that and tie the hands relating to insurance companies related to that. And that's what's termed fraud, waste, and abuse. And if we need to come back and strengthen that in the future, that if we do see that, but I think your point is well taken. From a parity standpoint, I mean, I think that we do feel as if there has not been enough coverage related to that. But that's sort of our thought process related to that.
Sure. But just to follow up or to clarify, so what we're saying is that particularly for private insurance plans, that it would be the insurance companies determining the criteria for medical necessity for care?
Well, I mean, they have to. It's lines 58 through 62, which I had just read, or 64. That's going to be the definition that they're going to fall back on, and that will be through the Department of Insurance. You're right. Any other thoughts or questions?
I guess the only thing I'd mention, Dr. Al, is I practiced OBGYN for 27 years before I got into management, and that was a stupid mistake on my part. But managing doctors is much more complicated than practicing medicine. These doctors here are exceptions, of course. They are delightful, but when I schedule someone for a hysterectomy, I had to get prior approval, and the 90% of the time, those things go through. You give them the reasons, and they're approved. 10% of the time, they throw up a barrier and say, I don't agree with you, or there's not enough documentation, or you need to do this test, and those are frustrating, but it's just part of practicing medicine. Those patients have a payer, and when there was a disagreement, they have an appeals process, and you have to go through that. And in my mind, that what we were trying to accomplish here is parity, and the process is the same whether it's a mental health condition or an acute illness, in my mind, with our definition.
Just to close that out, I just wonder if this weakens the original intent of the parity section of the bill itself. The second question, unrelated, in section 4, I think. In the House version of the bill, it's from lines 1514 to 1516.
Okay.
If you have the original House version.
I do. Yeah.
Okay.
I think we all do in our folders.
It should be in the pile, the paper pile.
Yes, in the pile.
There
I'm sorry.
was,
What were those lines again now?
So it's 1514 to 1516. Related to the co-response teams. And there was a piece in there that I just wanted to make sure translated over, or to see if it translated over to the new sub of the bill, that had to do with that the co-response team should utilize culturally and linguistically capable personnel or materials. I think I mentioned that in our first committee meeting. And I was trying to comb through and harmonize the two bills. Is that specificity of that language and the cultural competency and the linguistically capable personnel, does that translate over into the new?
Okay, so that was in the other sections that were removed.
Oh, is there an equivalent nod to that, the importance of that for community outreach? Because I feel that that's important to keep in.
Okay. We'll certainly consider it, absolutely. Is Senator Walker?
Thank you, Mr. Chairman. I'd just like you to help me be sure I understand what we're doing in Section 3-3. Looks like current law is 1,058 through 1,066 are the lines, and currently a peace officer can take somebody in for an evaluation if they have committed a crime and they think that they are mentally ill. And then the new language 1067 through 1078 adds that they can if the police officer thinks they're mentally ill, they can do and so the committing a crime piece is not in that section.
So we did not change any criminal code. If they've committed a crime, they've committed a crime from that perspective.
So the second part that we added is if the peace officer thinks there's a mental health issue, then they can do a telehealth visit, and then if the physician determines that yes, it is a mental health crisis, then they would be taken in for an evaluation. Is that on an outpatient?
Well, they would be taken into an emergency receiving facility, and that's where the 1013 would actually be done.
Like one of our crisis centers, like a CSB
Exactly.
type crisis center?
Yes, right.
And are they held then for the 3 days? Or?
No, not always. I mean, I can just remember when they did testify. Sometimes they go in, they get the services, they get the appointment to their psychologist or psychiatrist or social worker. They get plugged in. They may have an appointment there. They may have been out of their medicines. They may need their monthly shot. So no, they're not always admitted.
I mean, they're not being committed or anything at that point.
No, remember the 1013 is an evaluation.
And then I think, one other question, I think there's other ways, like just 2 family members could
Yes.
do that, or a judge could do it.
That's right.
And
that's
that's
right.
in current statute.
That's correct. And the lawyers on the committee could probably explain that better than the healthcare person on the committee, but maybe not. But yes, that is correct. 2 people can go to a judge and do a 1013 also. And again, it's an evaluation. It is 3 days of evaluation. The one that we're putting in there though is not necessarily means that they're going to be there for 72 hours. Chairman Burke.
Yeah, I just want to clarify, it's up to 3 days. And you made the point that they're frequently evaluated in that setting and are released almost immediately once the facts of the case are evaluated and the patient is determined to be safe to be released. So,
as a matter of fact, the facility in Savannah that I had a tour, I think they're evaluating on average about 8 patients a day, and you could imagine over 4 days that's 32. So they've already, or 3 days, that's 24. So they're already above their capacity. So they're not admitting everybody that comes in the door, everybody's that brought in, by the co-responder unit.
Okay. Thank you.
Mm-hmm.
Follow up the question with the senator from the 20th. If they're diagnosed with some sort of mental disability and they're doing a criminal activity, do the police officer or the peace officer take them to the mental health facility and then to jail, or?
We are not altering the criminal code at all.
So they go to the jail?
Well, I mean, if they've had a crime, then that's generally what happens.
All right, sir.
Yes. All right. You're at 2?
3.
3. Okay. All right.
We still have some questions over here, if you don't mind, Mr. Chairman.
That's what we're here for. This is a big bill. We got you.
Thank you. So current code, you have to have committed a penal offense, and then you get 1013 if the officers suspect that's also coupled with a mental health issue.
Right. Old language, not unchanged.
Right. The old language is unchanged. What's the impetus, or could maybe you give me a scenario where the old language would not apply, where the new language would apply, that we deemed it helpful to add?
Well, I mean, that's a great question. If you look at the examples that they gave, I mean, listen, the one that everybody talks about is the person who's, on the bridge, Talmadge Bridge, about to jump off. I mean, listen, I run across town, or used to when I was running, I would run across Talmadge Bridge. But if you are about to contemplate suicide and jump off, then that's a situation. That's the one that gets the headline, so to speak. But there are also people walking down the middle of the street without clothes on, or doing things that are obviously they're having mental health, a crisis in mental health. but most of the time it's not as dramatic as that. It many times is in the home when parents are struggling or spouses are struggling with their spouse, that kind of thing. So those are situations like that too. The police officers may be there and realize that this is really not an issue for crime relief or crime enforcement, but it's more of a mental health issue. And then they may call in the co-responder units themselves, and then they would go back to fighting crime, and then the co-responder unit would be there. And you got to remember, it's I think that a lot of them were quoting, I think in your county they quoted, I think 280 so people were seen, and maybe I was less than 5 or so were actually arrested. Most of them were not quite that good. I mean, it was a 90% arrest rate gone down to a 10% arrest rate, or 80% arrest rate gone down to a 20% arrest rate. But they were plugged into a place where they were supposed to be. I'm not rushing anybody. I want us to look at this and, you know.
I have another question if nobody else does, Mr. Chairman.
Absolutely. Okay.
I guess my last remaining largest question is around Section 2 and these cancelable loans.
Mm-hmm.
In the old fiscal note, which I know no longer applies, but that was a $10.3 million annual expense, and it did not include the primary care physicians, as I understand it. I believe that was added in this version of the bill, if that's correct.
And that starts on page 26.
It does. The primary care piece was added. I guess I have a couple questions around that I'll just state, and then I'll state a couple more questions, and you can answer them all at one time. Are we seeing a shortage of primary care physicians in the state of Georgia such that all of them, whether they practice in, my county, which is a desirable county to live, or whether they practice maybe in rural Georgia where they may not be as naturally drawn to, such that we're going to, if I'm reading this correctly, we're going to forgive the loans of all primary care physicians if they start out of medical school in Georgia and serve for 1 year per year of their loan. But then the second thing that I noticed I just want to clarify as well is that we're also going to forgive the loans of all psychiatrists, psychologists, professional counselors, social workers, marriage and family therapists, clinical nurse specialists, and psychiatric or mental health, or other licensed mental or behavioral health clinicians or specialists. I guess my second question would be, I assume the second part that I just read is the $10.3 million that was in the previous bill. And then we have an unknown number when we add all primary care that we'll get before we see the bill on the floor. Is that accurate?
And I'm going to let Chairman Burke answer that. If you look at line 753, page 30, it says practicing as a mental health substance use professional in a geographic area in the state of Georgia approved by the authority. So those are underserved areas where they are doing that, but so there's a need. And now, having said that, yes, Georgia is ranking the last ones I recall, and Chairman Burke may remember better, but we are underserved when it comes to ratio of physician to population, where I think we're in the 40s somewhere from primary care standpoint. Psychiatry is like that also, but these are in even more underserved areas. That's what it is.
And does the underserved portion only apply to the mental health piece, or does it apply to the primary care piece as well?
I think I can clarify, Senator, if you look at line 668, that's following from the last part of 667, the authority shall from time to time by regulation designate the subfields of study that qualify for the service cancelable loans under this paragraph. So these will be regulated and decisions will be made as what's most appropriate. And that's what the current process for the service cancelable loans are today. So it's not like anybody that applies can get it, is my point. Obviously, we want to get a new fiscal note to evaluate, and being someone who's on appropriations and takes, the budget process very, very seriously, in my mind, the workforce is the critical issue here that we've got to address. And if that's $10 million a year that we need to put towards that so that we have adequate access for this type of coverage, I'm willing to recommend that. Obviously, that's up to this body to make those decisions. And I certainly want to make sure we have a fiscal note that would clarify the impact. And I'm sure that between now and before this bill gets to the floor, we can have somebody from that authority that does this in their real job already. We can have some questions answered to make sure your concerns are evaluated appropriately.
Do you know, if I may, Mr. Chairman, do you know if this loan forgiveness is only relative to the graduate work, or does it include the undergraduate work as well?
The part about the mental health providers would be someone who is licensed to provide services. So, in other words, to be licensed, you've got different categories, and I'm not the world's expert. Most licensed mental health professionals are probably would be the equivalent of a master's level, but I don't know every one of them. So.
Okay.
Thank you, Mr. Chairman. And this is not as much a question as it is just a comment. Obviously, mental health is a major issue in the state, which is probably the reason behind this bill. Is the reason behind this bill, and I just wanted to say to the people who've been working on this substitute for the last week or so, the number of calls and emails that we've gotten expressing concerns about the legislation. I just wanted to say that it seems like y'all did a very good job addressing those concerns, and I just wanted to thank you guys for the hard work, and hopefully this bill will do a lot of good for mental health in the state of Georgia.
Thank you, Senator Hatchett. We appreciate your thoughts. Any other questions? Okay. I don't see any other questions, so I will stand for a motion then. I'll entertain a motion from the committee.
Your subcommittee chair is ready.
My subcommittee chair is ready. You want to make a motion?
I'd like to make a motion, Mr. Chairman, to do past LC 33915-2S.
Second.
And we have a second. Do we have a discussion? We do have a small amendment on line, I think it's 1242. Everybody turn there. I think it's actually in your folder, 1242. I'll offer it up as an amendment, 1242. Striking the word tracking on line 1242. 1242, page 49. It says identifying, tracking, and treating those under community supervision. We're offering up a committee to strike the word tracking.
What page? What's the line number, Mr. Chairman?
Okay. Okay, I'm standing correctly, 1241. Okay. Identifying, tracking, and treating. Did I get that?
Yep, 42.
1241. Is that a different? It is the same LC, but it's a different number. So if we look at the line that says, what did we say it was? 1241, to assist state and local agencies in identifying, tracking, and treating those under community supervision. And it starts with in identifying. We are removing the word tracking. like to offer that as an amendment.
Second.
Second. All those in favor of the amendment, raise your hand. Oops, I'm not voting. So, all right, did you get that? Let's do that one more time. All those in favor of this amendment, raise your hand. Okay.
I'm sorry.
All right. I thought you were going to vote against it, so that's that's
Well, I did have a question
That's-
about it, about how you're going to accomplish
that's
that.
unanimous. Gotcha. All right. All right. So now we're in the posture of the House Bill 1013 LC 33915-2S as amended. Any further discussion? All those in favor, raise your hand. That looks unanimous. Okay. Alrighty. I want to thank the subcommittee. I want to thank the House members. I want to thank the folks who have testified, experts, citizens, and everyone. I want to thank the Georgia State Patrol and Capitol Police. And thank you very much. Meeting is adjourned.
Thank you, Mr. Chairman. Good job.